Assalamu alaikum. It's a new way of learning, like 10 facts in a day. I would like to discuss about the 10 questions or 10 facts regarding obstetric and gynecology. Starts with this question. A 30-year-old woman, gravida 1, para 0, 29 weeks of gestation. Look, in this question there is two real thing. The platelet count. The platelet count in initial visit at 10 weeks of gestation. What is this? Is 2,40,000. But now her platelet count is 1,18,000. So her platelet count is reduced. Also, we have to look for the reason why their platelet count is reduced, but there is no problem, only there is edema. In pregnancy, edema is normal, but fundal height is normal, heart rate is normal, lungs are clear, no problem. There is no third trimester HIV and syphilis. What should be the most appropriate management? It should be reassurance and observation. So thrombocytopenia in pregnancy is normal. There may be gestational thrombocytopenia like this patient, isolated mild isolated mild thrombocytopenia, which is in between 1 lakh to 1 lakh 50,000. It is asymptomatic and it is a diagnosis of exclusion. We can see her blood pressure too. Blood pressure is normal. If it is P in preeclampsia, there may be BP is more than 140/90 after 20 weeks of pregnancy with proteinuria, with or without organ damage. This is the definition of preeclampsia. In preeclampsia, it is moderate to severe thrombocytopenia with severe features hypertension, headache, and scotoma. Hypertension, headache, and scotoma. There may be uh, increased creatinine and AST, ALT would be high. In ITP, that means idiopathic thrombocytopenic purpura or immune mediated thrombocytopenia. In here, there is isolated moderate to severe thrombocytopenia. It is asymptomatic or mucosal bleeding or bruising. There is normal PT and APTT. In ITP, in TTP, there is normal PT and APTT, but the difference is in TTP, platelet count is very low, less than 30,000, and there may be neurological feature in thrombocytopenic purpura. There is Raynaud's sphincter. There is thrombocytopenic purpura along with fever and neurological. There may be fever and neurological problem. This is called Raynaud's sphincter. But in here, normal PT and APTT. But if it is DIC, it is moderate to severe uh, thrombocytopenia. But there is bleeding or oozing, IV sites, and increased PT, APTT, and low fibrinogen. There is increased PT, APTT, and low fibrinogen. So that is the answer of this question. And we do this 24-hour urine collection for total protein is to evaluate for PE, preeclampsia, which can cause thrombocytopenia. NA is done to see the autoimmune disorder like SLE, and coagulation disorders can be used to evaluate patients with thrombocytopenia. Next question is, if Estradiol and estrone are undetectable. That means, but FSH, LH, testosterone, and androstenedione are high because testosterone is converted into dihydrotestosterone or estrone. Androstenedione is again converted into estrone and so there is an enzyme called aromatase which helps in this conversion. If this enzyme is deficient, this aromatase is deficient in the adipose tissue. If aromatase is absent in the ovary, so for this absence, androstenedione cannot be converted into estrone, so low estrone, and testosterone cannot be converted into estradiol, so low estradiol in the ovary, low estradiol in the ovary, and low estrone in the adipose tissue. That's why, and this is the answer of aromatase deficiency. And the other is McCune-Albright syndrome. There is calf or late spot, polyostotic fibrous dysplasia, and autoimmune endocrine hyperfunction. These three are the triad of McCune-Albright syndrome. Ovarian hypertrichosis is a cause of virilization, but it is typically diagnosed in postmenopausal women, but it is premenopausal women. It can cause virilization, it can cause pre-realization female. So congenital aromatase deficiency is a rare enzyme deficiency that prevents conversion of androgen to estrogen. It causes virilization of the female fetuses resulting in normal internal genitalia with ambiguous external genitalia. Normal internal genitalia with ambiguous external genitalia. This woman has retained placenta, required DNC, and there is multiple blood transfusion is needed. In vaginal delivery, if multiple blood transfusion is needed and patient is unable to breastfeed the child, so diagnosis is done. It is Sheehan syndrome. There is pituitary gland infarction. Treatment is corticosteroid and ERPR replacement therapy. Corticosteroid and ERPR replacement therapy. How you diagnose Sheehan's? See the cortisol level, thyroxine level, FSH level, and prolactin level. Cortisol level, thyroxine level, FSH level, and prolactin level. This is the way of diagnosing Sheehan's. So in next question there is hemoglobin normal, platelet is normal, but the leukocytes are high. Leukocytes are high. Cervix is dilated, fetal head. Uh, mm, in here the mom is febrile. The blood pressure is normal. Febrile mom, maternal leukocytosis, diagnosis done. Um, chorioamnionitis or intraamniotic infection. In intraamniotic infection, such as chorioamnionitis, the most common complication in the most common complication in common patient with prom, which occurs before the onset of the regular contraction in uh, those with prolonged rupture of the membrane, in those with prolonged rupture of the membrane more than 18 hours, patient with IAI, intrahepatic infection, nausea, vomiting, and uterine local tenderness and uterine local tenderness. These diagnosis is based on the presence of maternal fever plus at least one of the following: fetal tachycardia, maternal fever, there is mom is febrile and fetal heart rate is more than 160, and mm, patient may have an abnormal contraction pattern due to effect of intraamniotic infection on efferent muscle contractility. In premature rupture of the membrane, there is increase the risk of in premature rupture of the membrane, increase the risk of abruption of placenta with visible bleeding, and there is non-reassuring vital heart rate tracing. Non-reassuring vital heart tracing. Now, in addition to broad spectrum antibiotic, which of the following is the next best step in this patient? So, in chorioamnionitis, the next best step after giving antibiotic, broad spectrum antibiotic, you should do labor augmentation. So this is chorioamnionitis. What you have to remember, all the P's, that means prolonged rupture membrane more than 18 hours, preterm, pre-labor, rupture of the membrane, prolonged rupture of the membrane, preterm, pre-labor, rupture of the membrane, and prolonged labor, and presence of genital tract pathogens. So four P's, and then an I, internal fetal or uterine monitoring device. Internal fetal or uterine monitoring device. And repetitive vaginal examination. This is must, no must. In developing countries, what happens? The most of the delivery is done by the quacks or the unprepared persons, so they do repetitive vaginal examination and thus causing this sort of intraamniotic infection. Although diagnosed, there is maternal fever plus one of the features like fetal tachycardia, maternal leukocytosis, and purulent amniotic fluid. In here, there is maternal leukocytosis more than 18,000 and some sort of tachycardia also present. Management: broad spectrum antibiotic and delivery by you have to do labor augmentation. Complication: maternal postpartum hemorrhage and endometriosis, and the neonatal is preterm birth, pneumonia, encephalopathy. Preterm birth, pneumonia, and encephalopathy. So prolonged rupture of the membrane, preterm pre-labor rupture of the membrane, preterm pre-labor rupture of the membrane, prolonged labor, uh, presence of genital tract pathologies, internal fetal or uterine monitoring device, and repetitive vaginal examination. Maternal fever plus one of the following: fetal tachycardia, maternal leukocytosis, and amniotic fluid. Purulent amniotic fluid. Next question is: this 29-year-old woman, gravida 2, para 1, 41 weeks of gestation, comes to the office for a routine prenatal visit. He has no abdominal pain, leakage of fluid, or vaginal examination. Fetal movement is normal. He has done group B streptococcus screening and 37 weeks of gestation negative. Her pregnancy ended in post-term vaginal delivery, non-stitched is variably multiple acceleration, uh, ultrasound of the fetus in a vertex presentation, and the single pocket amniotic fluid is 1.2 centimeter. What should be the next step? It should be induction of labor in late term or post term. What you have to do is to induction of the labor late term more than 41 or more than 41 weeks of gestation. Late term and post term is 42 or more than 42 weeks of gestation. Prior post term pregnancy, nulliparity, obesity, age more than 35, and fetal anomalies, and fetal anomalies. Complication is macrosomia, oligohydramnios, dysmaturity syndrome and demise, maternal case, severe obstetric laceration, cesarean delivery, PPH, frequent fetal monitoring, non-stress test and delivery prior to 43 weeks of gestation, delivery prior to 43 weeks of gestation. If signs of uteroplacental insufficiency include late deceleration, non-stress test, oligohydramnios, single deepest pocket is less than 2 cm. It is oligohydramnios on ultrasound. Oligohydramnios occurs due to uteroplacental insufficiency because fetal blood is shunted from kidney. Fetal blood is shunted from kidney to the brain and to prevent central nervous system suppression in chronic fetal hypoxemia. Oligohydramnios occurs due to placental insufficiency. Fetal blood is shunted from the kidney, which produce amniotic fluid uh, to the brain to prevent central nervous system suppression from the chronic fetal hypoxemia. This is all about late and post-term pregnancy. This is very easy question, but I have made a mistake that this patient, this is diabetic patient, she is on insulin. She has B or not. I have to look for. That's why 24-hour urine collection for total protein. 24-hour urine collection for total protein. Key can be the risk factor of pre is nulliparity. This is nulliparity, obesity, pre-existing medical condition like SLE. This woman has SLE. She is nulliparous. She has some sort of SLE. She has some sort of obesity, pre-existing medical condition, SLE, chronic hypertension, multiple gestation, and advanced maternal age. Definition is new onset hypertension, systolic blood pressure, um, 140 or more than 140, or diastolic blood pressure more than 90 millimeter of mercury at 20 weeks of gestation, and proteinuria or signs and symptoms of other end organ damage. Severe range hypertension, systolic blood pressure more than 160 and diastolic more than 120, platelet less than 1 lakh, creatinine more than 1.1, or elevated transaminase more than 2 or more than 2, the upper limit of the normal, pulmonary edema, vision or cerebral abnormality. Next is in here there is urine 4 plus protein. She has high LDH. She has features of eclampsia. He has headache, blurry vision, fatigue, and BP is very high. So she is eclamptic. Uh, Patient, which of the following complication in eclamptic preeclampsia complication is small for gestation age, small for onset of maternal hypertension at 34 weeks of gestation, onset of maternal hypertension and 34, so small for gestation age, small for gestational age. The this pregnant patient with severe range hypertension, systolic blood pressure more than 160 and diastolic more than 110, proteinuria, preeclampsia with severe features. She has preeclampsia with severe features which likely occurs to abnormal placental development under normal conditions. Early cytotrophoblastic invasions remodels the uterine spiral artery into the high blood flow. Low resistance vessels that increase oxygen and nutrient delivery to the growing fetus and the placenta. In contrast, abnormal cytoplastic invasion in preeclampsia results in low flow, high resistance vessels that cause decreased placental perfusion. However, during third trimester, there is rapid fetal growth, 0.2 kg per week. There is rapid fetal growth, 0.2 kg per week. The chronically underperfused placenta cannot provide adequate oxygen to the fetus. So, in patients with preeclampsia, uteroplacental insufficiency often coincides with the onset of widespread vaginal constriction and end organ damage. So, resulting in small for gestational age. 34-week gravid one, 34 weeks of gestation. The patient is recently moved. Urine dipstick is negative for protein and glucose. Ultrasound normal. The patient would like to attempt a vaginal delivery with his pregnancy. He has to schedule a cesarean delivery at 37 weeks of gestation. The most important point I have missed, that is the there is shows a posterior placenta, normal amniotic fluid volume, and a fetus in a frank breech presentation with an estimated fetal weight at 50 percentile. So patient with breech presentation. So patient with breech presentation, a fetal malpresentation, breech presentation in which buttock and feet are the part to the closest are the parts closest to the maternal cervix are typically managed with caesarean delivery. Breech presentation mammals are at term. These patients, so in here patients with breech presentation typically offer an external cephalic version which manually rotates the fetus to a cephalic presentation. In contrast, those with breech presentation and contraindication to vaginal delivery prior classical caesarean delivery placenta previa, external cephalic version is not performed and patient undergoes caesarean delivery at 37 weeks of gestation. At 37 weeks of gestation, in pregnancy, you should do just normal jogging and you have to leave the competitive sports like contact sports, high for risk scuba diving and hot yoga. You should leave these type of exercise. And that's all about 10 questions uh, in ops. I would like to discuss in these way 10, 10, 10, 10. That's all for today. Hope you enjoyed.